Well, welcome to this talk on the liver, which is the largest solid organ in the body, with only the skin having a greater total mass. But in terms of the condensed tissue altogether in one place, the liver is the largest organ. And in men it normally weighs about 1.4 to 1.8 kilograms, and about 1.2 to about 1.4, slightly less in women. And the liver is involved in many of the biochemical processes which are necessary within the body. And this is why the liver is often referred to as the chemical factory of the body. So if ever you're talking about a biochemical process and you're not quite sure where that process is going on, it's most likely that it's occurring in the liver, this biochemical factory of the body. So anatomically, we can see the liver occupies most of the upper right quadrant of the abdominal cavity. Rounded upper surfaces fit snugly under the domed diaphragm, but the lower surfaces are more tapered, giving a fairly wedge-shaped appearance from the side. Now, young children have a much bigger liver relative to the size of their body. And this explains why the upper abdomen protrudes in young children, because relative to the size of the body, their liver is disproportionately large. And we see on this diagram on the left that the liver is in the upper right, and then on the upper left we have the stomach, and also tucked under there that we don't see in the upper left quadrant of the abdomen we have the spleen. Now in the diagram on your right, we've taken away the lungs, and we can see the blue line of the diaphragm separating the thoracic cavity above and the abdominal cavity below. And we can see the rounded top of the liver fitting neatly underneath the diaphragm. And we can also clearly see there from the cross-section of the ribs that the liver is somewhat protected by the ribs of the thoracic cage, particularly the right-sided ribs. We notice the two large lobes of the liver, the right lobe and the left lobe, and just tucked under there in green, I think you can probably see the tip of the gallbladder. Now, it is accurate to classify the liver as an exocrine gland. That's one of its functions, because it produces about 500 mils of bile per day. And this bile is secreted from the liver via the right and left hepatic ducts, and these merge to form the common hepatic duct. It's the cystic duct that transports the bile from the common hepatic duct to the gallbladder, and in the gallbladder the bile is stored and concentrated. And then the same cystic duct carries the bile out of the gallbladder into the common bile duct. Now, the pancreatic duct merges with the common bile duct before it communicates with the duodenum. And this arrangement means that the bile and the pancreatic juice both enter the duodenum together via the hepatopancreatic sphincter, what used to be called the sphincter of Oddi. Now, the liver is receiving about 70% of its blood supply from the hepatic portal vein, the vein which drains blood directly from the gastrointestinal tract to the liver. And on average, slightly over a litre of blood per minute passes into the liver from the hepatic portal vein. But in order to support metabolism, liver cells also need a supply of oxygen-rich blood. And this comes from the hepatic artery. So the other 30% of the blood supply to the liver is coming via the hepatic artery. Now, the blood entering the liver from the hepatic portal vein is only partly deoxygenated. It is still supplying some oxygen. But remember, the blood entering the liver via the hepatic portal vein has already circulated through the wall of the gut. So we'll have lower concentrations of oxygen. So to top that up, oxygen-rich blood from the hepatic artery also enters the liver to perfuse the liver with oxygen-rich blood for all these processes of metabolism that are going on in the liver. Because the liver is a very metabolically active organ, therefore needs a large oxygen supply. After circulating through the liver, venous blood is drained into the inferior vena cava via 3 hepatic veins. Now, the hepatic portal vein and the hepatic veins should not be confused. The hepatic portal vein carries blood to the liver from the gut, whereas the hepatic veins drain blood from the liver back into the systemic venous return of the inferior vena cava. So on this diagram we see that blood is leaving the heart via the aorta, and the hepatic artery is going to be a branch off the aorta. So the oxygen-rich arterial blood from the left side of the heart is entering the liver via the aorta and the hepatic artery. But there's also blood entering the liver via the gut. So you can see the gut at the bottom. The gut is drained by the hepatic portal vein, and that is taking nutrient-rich blood from the gut into the liver. And that blood going to the liver from the gut will also contain bacterial breakdown products going to the liver to be metabolized before they enter the systemic circulation. When the blood from the hepatic artery and the hepatic portal vein have been perfused through the liver, when they've passed through the liver, then all that blood will drain in the 3 hepatic veins, represented by 1 vein on this simplified diagram. And also on this diagram, I've drawn a dark arrow going down the way from the liver to the gut, which is the direction of bile. So the bile is produced in the liver, going down through the bile ducts and the gallbladder, also entering the gut. So here we're thinking out about the blood supply to the liver. Now, the hepatic artery is going to take oxygenated blood directly to the liver. The aorta, as you know, derives from the left ventricle, and the hepatic artery is basically a branch from the aorta. The hepatic artery actually divides into the right and the left hepatic artery, the 2 main branches of the hepatic artery, taking blood to the right and the left lobe. So the right hepatic artery is going to take blood to the right lobe. The left hepatic artery is going to take blood to the left lobe. And this is going to deliver about 70% of the blood supply to the liver. But along the bottom here we notice we have the gastrointestinal tract. So this is the gastrointestinal tract. And this is drained by various veins. So for example, there's the splenic vein draining the spleen. The superior mesenteric vein drains the jejunum and the ileum. The inferior mesenteric vein drains the colon. The gastric vein drains the stomach. The cystic vein will drain the gallbladder and bile ducts, but they will all take blood. All these veins will come together to take blood into this vein here, which is the hepatic portal vein. So basically the hepatic portal vein is draining the spleen and most of the gastrointestinal tract, draining blood straight into the liver. So this is the hepatic portal vein. Now the common bit's about 8 centimetres long. It's in the upper right quadrant of the abdomen. Now a portal vein is a vein which will begin and end in capillaries. So this vein begins in the capillaries of the gastrointestinal tract, or the spleen, carries blood through this large venous section, and then this is going to distribute into lots of small capillaries in the liver. So that means that the blood from the gastrointestinal tract comes into contact with a lot of the liver tissue. So if we describe a portal vein as one which begins and ends in capillaries. And the only other one in the body is the hypophyseal vein from the hypothalamus to the anterior lobe of the pituitary gland, carrying the releasing factors. So why is this arrangement as it is? Well, the gut contains lots of toxins derived from bacteria. And even some bacteria themselves could escape into the blood supply from the gut. That's why in the liver there's numerous hepatic macrophages to phagocytose any bacteria which manage to escape. And also the bacteria in the gut are going to be producing lots of toxins all the time. And we don't want these toxins to get from the gut into the systemic circulation. So the toxins are filtered through the liver first of all. And that's good, filtering things through the liver, because the liver can detoxify the toxins. That's one of the functions of the liver. That means when the blood has gone through the liver and it's going to be drained via the hepatic veins back into the inferior vena cava, which will go back to the heart, of course, that the toxins have been degraded and broken down and metabolized. Otherwise, with these toxins going into the blood all the time, we'd all feel sick all the time, which would just be terrible. Now, if there's cirrhosis in the liver, that's going to make a backlog of this blood in the hepatic portal vein, and that can cause portal hypertension with various complications if there's cirrhosis in the liver obstructing the blood flow. But under normal circumstances, in happier days, the liver, of course, is producing, or the gut rather, is absorbing lots of nutrients which are going to go to the liver to be processed. Amino acids and monosaccharides and useful things will be processed in the liver. The biochemical factory of the body, the liver does all this sort of processing. And then once the blood has been through the liver, it's going to drain via the hepatic veins. So blood from the liver lobules, or the central vein in the liver lobules, will collect together into smaller veins and larger veins. Now there's three large upper hepatic veins, the left, middle and right, draining the three parts of the liver. And there's also several lower hepatic veins. But it doesn't matter too much for the purposes of this talk. They all drain from the hepatic vein into the inferior vena cava. And of course the blood's going to be relatively low in oxygen, high in carbon dioxide. But it's also going to contain nutrients. In periods of fasting, it will contain more glucose because glycogen from the liver will be broken down. And blood in the hepatic vein will contain less toxins because, as we've said, the liver breaks down toxins. And this is also true for drugs. So drugs taken enterally are absorbed via the gastrointestinal tract, but some of that drug is metabolized in the liver. This is called a first pass effect or first pass metabolism. So the first time the drug goes through the liver, it'll be relatively high. It'll be in relatively high concentrations because it's come from the gastrointestinal tract. So it'll be in relatively high concentrations and the liver's able to metabolize a proportion of that. And that's called first pass metabolism. That's why the dose we give of enteral drugs is often higher than the dose we give of drugs that we're going to give intravenously or parenterally via intramuscular injection or some other parenteral route. So the blood supply to the liver, 30% the highly oxygenated blood from the aorta and hepatic arteries, 70% from the gastrointestinal tract for all this biochemical processing. Now it's true that the liver is a very metabolically active organ, so it does need a good oxygen supply. That's why we have the hepatic artery. But of course the blood draining from the gut is not fully deoxygenated. It's probably still got oxygen saturations of around 75%, so it's still useful in terms of oxygen. And finally on this diagram we notice the bile being formed by the liver, which is also draining into the gastrointestinal tract, giving another aspect to this interesting aspect of circulation. So a very important aspect of the circulatory system, processing nutrients, killing bacteria, breaking down toxins, and something we need to take account of in our pharmacology. Now the liver is actually composed of 4 lobes, but only 2, as we've seen, are visible from the front. The ones that are visible from the front are simply called the right and the left lobe, the right being significantly larger. But from the back we can see the caudate lobe and the quadrate lobe. And also looking at the liver from the back, as we are doing in this photograph, we see that the left lobe is on the left and the right lobe is on the right as we view, because we're now looking from the back, of course. And the underside of the liver is beautifully sculpted to facilitate the way it sits on adjacent inferior organs. When we say inferior, of course, we mean below. So we notice the gastric impression on the underside of the left lobe, which of course is where the stomach will sit. And we see the renal impression on the right lobe for the top of the right kidney. Now we also notice the inferior vena cava on this model, and underneath this section of the inferior vena cava, if we could see through the inferior vena cava, we would see the 3 hepatic veins draining into that section of the inferior vena cava. And we also notice the hepatic portal vein carrying blood into the liver and the hepatic artery carrying blood into the liver. Remember, the hepatic portal vein is carrying in about 70% of the total blood supply to the liver. And looking at the underside, we also see the cystic duct, the common bile duct, the common hepatic duct, and the gallbladder itself tucked neatly underneath the liver. Now we've noted that the liver has 4 lobes, but the liver also contains thousands of lobules. So within the lobes of the liver are numerous lobules, separated from each other by connective tissue. And these lobules are usually 5 or 6-sided structures, and they are cylindrical. At the corners of the lobule are branches of the hepatic portal vein, hepatic artery and bile ducts. And collectively these 3 vessels are referred to as a triad. And a normal liver contains between 50,000 and 100,000 lobule units. And an individual lobule unit varies in diameter from about 0.8 to 2 millimeters across. So these diagrams are starting to explain the histology of the liver, the way the liver is actually arranged at an increasingly smaller scale. So the top left we have the diagram of the liver, and the top right we have the diagram of the liver or hepatic lobules. And then the diagram on the bottom right is a magnification of an individual hepatic lobule. Now it's the hepatic lobules that are the functional units of the liver. The individual liver cells are called hepatocytes. And in an individual lobule, hepatocytes are arranged around a central vein, like spokes around a hub in a wheel. It's a radial arrangement of cells, as we can see in the bottom right diagram. Typically, the hepatocytes are arranged in a row, 2 cells thick. And these 2 rows of cells are described as a hepatic cellular plate. So we can see these hepatic cellular plates within an individual lobule in the bottom right-hand diagram. What we're looking at here is a simplified slice of a lobule. So if I'd drawn this diagram properly, these would radiate all the way around the central vein, but I've just drawn one slice. And blood enters from small branches of the hepatic portal vein and the hepatic artery. So that's the blood going in. And the arrows indicate the direction of blood flow from the outside of the lobule towards the central vein of the lobule. So the sinusoids are in essence the hepatic capillaries. In between two hepatic cellular plates are the blood sinusoids. And as we say, these are the liver's version of blood capillaries. So a sinusoid is essentially a type of blood capillary with very porous walls to allow more contact than usual between the blood and the tissue cells. And this increased permeability of the liver sinusoids is explained by the large pores found in the cells, which make up the endothelial vascular wall. And these large pores are referred to as fenestrations, explaining why liver sinusoids are sometimes referred to as fenestrated capillaries. Now, unlike other capillaries, sinusoids receive blood from two sources. Firstly, from a branch of the hepatic portal vein, bringing blood from the gastrointestinal tract or the gut, and secondly, from a branch of the hepatic artery. And this arrangement means venous blood and arterial blood mixes in the sinusoids as it passes through a lobule, from the outside of the lobule towards the central vein at the centre of the lobule. So hepatocytes are therefore supplied with nutrient-rich blood from the hepatic portal vein and oxygenated and oxygen-rich blood from the hepatic artery. Hepatocytes lining the sinusoids are able to selectively absorb substances from the blood, carry out chemical processes, and then secrete the products back into the blood of the same sinusoid. In the centre of each lobule are small tributaries of the hepatic vein. Remember, it's the hepatic vein taking blood from the liver back to the systemic circulation. Blood from the sinusoids drains directly into this central lobular vein. And this vein joins up with other lobular veins, which eventually become one of the three large hepatic veins, taking the blood back from the liver to the inferior vena cava and therefore back into the systemic circulation. So we've noted that in the liver sinusoids, the blood comes into very close contact with the hepatocytes, the liver cells. But as well as that, in the sinusoids, there's macrophages, because there's a hepatic macrophage system. Now, liver sinusoids contain these macrophages lining the walls. They have been called various things in the past. Comforter cells or part of the reticuloendothelial system are old-fashioned names that you might come across. But basically they're macrophages. These are the large phagocytic white cells that derive from monocytes. Now, like their counterpart macrophages in the spleen, the liver macrophages will also break down some old red blood cells, recycling amino acids and excreting the bilirubin. But most of this process takes place in the spleen, but some does take place in the liver sinusoids. But in addition, the macrophages in the liver perform a vital immunological function. Because if you think about it, quite a lot of the blood that's going into the liver sinusoids is coming from the hepatic portal vein. And the hepatic portal vein is draining the gastrointestinal tract, which of course is full of bacteria. So some bacteria will get into the hepatic portal vein and be transported to the liver. Now, it's vital these bacteria don't get into the systemic blood supply, because there they could cause bacteremia and potential sepsis. So as the blood from the hepatic portal vein goes through the sinusoids, any bacteria in that blood will be detected by these hepatic macrophages, and they will phagocytose the bacteria. So the liver sinusoids, if you like, are a first line of defence to stop bacteria from the gastrointestinal tract getting into the systemic circulation. They're strategically placed. to take the bacteria from this blood that's coming from the hepatic portal vein, draining the gastrointestinal system before it gets into the systemic venous circulation. What we're looking at here is a cross-section of part of a liver lobule. One of these sort of slices, a fairly thin slice in this case, of liver lobule. And this shows two hepatic cellular plates, that's two lines of hepatocytes, with blood flowing through the sinusoid in between. So you can see the branch of the hepatic portal vein, the branch of the hepatic artery, the central vein in the middle of the lobule, and the blood flowing towards the central vein. That bit we know already. Now, individual hepatocytes excrete bile into the canaliculi, which then flows between the two rows of cells to be collected in a small bile duct. So the canaliculi, here we see one canaculus labelled, are the bile channels. So the bile is produced in the individual liver cells, in the individual hepatocytes, and excreted into these channels, these canaliculi. So the bile, of course, is flowing in the opposite direction towards bile collection channels that ultimately will collect together into the right and the left hepatic duct to export the bile from the liver. Now, this diagram on the bottom left is a transverse section of the two rows of cells which form a hepatic cellular plate, the two rows of hepatocytes. And the canaculus is actually formed between the two rows of cells. So bile produced in the individual hepatocytes is only excreted into one canaliculi. This means bile is only excreted from one side of the hepatocyte, as the other side of the hepatocyte is in contact with the blood. And arrows indicate the direction of bile flow. So the bile is being produced in the hepatocytes, or processed in the hepatocytes, entering the bile channels to flow towards the bile collection channel that we can see in the diagram on the right hand side of this slide. So between the two rows of hepatocytes are microscopic channels called canaliculi. Individual hepatocytes produce bile which they excrete from the cells into these canaliculi. These in turn drain into the small bile channels of the triads. And the triads are the group of the three vessels we can see on the outer part of the lobule. So a triad is going to consist of a branch of the hepatic artery, a branch of the hepatic portal vein, and the bile collecting channel. So these in turn drain into small bile channels of the triads, which, as we've said, are tributaries of the larger hepatic bile ducts. And this arrangement means that bile flow in canaliculi is in the opposite direction to the blood, which is passing through the sinusoids. So the blood in the sinusoid is going from the outside of the lobule in. The bile which is produced by the hepatocytes is going in the direction from the inside of the lobule out. The separation of the sinusoids, that's the blood channels, and the canaliculi, that's the bile channels, prevent bile and blood mixing. And of course that's very important, because if bile gets into the blood, you probably know what that causes. Bile in the blood will lead to jaundice. But once formed in the physiological situation, bile flows into progressively larger bile ducts, which eventually unite to form the right and the left hepatic duct, and then the common hepatic duct, and then into the gallbladder, and the rest of the story you remember from a previous slide. In this diagram, which is a longitudinal section, it can be seen how a canaculus is formed between two rows of hepatocyte cells. The dark arrows indicate bile flow, the white arrows blood flow. So the blood is flowing from the triad towards the lobular central vein, and the bile is flowing away from the lobular central vein towards the triad. And as we can see, the bile is being collected in small bile ducts, and the blood is entering the sinusoid. And although the branch of the hepatic portal vein and hepatic artery are not illustrated in this diagram, we know that that is where the blood from the sinusoid comes from the hepatic artery and the hepatic portal vein. So in this video we're going to use some more diagrams to try and get a feel of the overall structure of the liver and the way the liver is composed of lobules. But from the front we notice that there's two main lobes in the liver. We've got the right lobe, which is here, the larger right lobe, and the smaller left lobe. So these are the lobes. Now there's actually two smaller lobes behind that you can't see from the front. But these are the large lobes, the large right lobe, and the smaller left lobe. And underneath here we can just see the tip of the gallbladder underneath the right lobe. And there's a falciform ligament that we see separating the two lobes of the liver. Now if we look at this in detail, we'll see that the liver is actually made up of these smaller lobules, these hepatic lobules. Now these are traditionally described as hexagons, and in humans they are reasonably hexagon, but they're not that regular. The original work was done in pigs, adult pigs, and they do have very regular hexagonal lobules, but it's still basically accurate for humans. The liver is made up of these lobules, and these lobules are very small. They're probably about 1 to 2 millimeters in diameter, and they're actually columns, sort of the columnar shaped structures, so they might be about 2 millimeters long, going into the plane of the diagram. So 1 to 2 millimeters in diameter. Now if we look at a single hepatic lobule, so this is one lobule we're looking at here now, one lobule, and we see it's made up of hepatic plates. Now the hepatic plates are made up of individual hepatocytes. So there's a hepatocyte, there's a hepatocyte, there's a hepatocyte, and of course in between these are all hepatocytes. So these are double rows of hepatocytes, and that makes up a hepatic cellular plate. So here I'm colouring in blue the hepatic cellular plates. And in the middle we have a central vein as well. Now around about the outside, on the corners of the lobules, we're going to have a branch of the hepatic artery, a branch of the hepatic portal vein, and also we're going to have a bile channel. So there's a branch of the hepatic portal vein, a branch of the hepatic artery, and a bile channel. Now just focusing on the blood vessels at the moment, the blood from the hepatic portal vein and the hepatic artery are going to go into this area here, and this is the area of the sinusoid, the liver sinusoid. The blood's going to pass down through the sinusoid into the central vein for drainage, into the central vein where it will drain. So the blood is flowing from the outside inwards. And as the blood goes through, because the capillary walls of the sinusoid, if we draw those here, exaggerate the size, They're the capillary walls of the sinusoid. We see there's very large gaps in between the individual capillaries, so blood components can get to the hepatocytes and from the hepatocytes back into the blood, so there can be exchange. And then when the material has been processed, it will drain into the central lobular vein. And if we look at that in another diagram, it's quite complicated, this, so the best thing to do is just look at several diagrams to try and explain it. So what we have on this diagram is we have a branch of the hepatic artery, just here, putting blood into the sinusoid. So this is a sinusoid, these are sinusoids here, the blood is flowing in this direction from the centre of the lobule, from the outside of the lobule to the centre of the lobule, towards this central collecting vein here. At the same time, blood from the hepatic portal vein, which I'm going to draw in blue here, as we've said before, the blood in the hepatic portal vein is partly oxygenated. But that will also go into the liver sinusoid, the liver capillary, and it will mix with the blood from the hepatic artery, and that blood will all drain towards the central vein. And again, this allows time for materials to be taken out of the blood into the liver cells. Here's the hepatic plates here, these rows of hepatocytes. The liver cells, the hepatocytes, quite large cells actually, and these are the functional units of the liver, forming these hepatic plates. So we see rows of hepatocytes composing cellular plates, and the sinusoids in between here. The blood capillaries. The sinusoids are just the name for the blood capillaries in the liver, really, with their very permeable walls. So blood is going into the sinusoid through a branch of the hepatic portal vein and a branch of the hepatic artery. Now, the liver cells, as we know, the hepatocytes, produce bile. So what they have is this side of the hepatocyte here, you could call that the blood-facing side, because that's in contact with the blood, and the same there, that's the blood-facing side. But the middle bit is the bile-facing side. Let me show you what I mean by that. So in this diagram, we see an hepatocyte. This would be the blood in the sinusoid on the sides, just there. So material from the blood will go into the hepatocyte for processing, be chemically processed in the hepatocyte, and can be excreted back into the blood. But the bilirubin and the other components of the bile, which are also produced in the liver cells, are going to be excreted out of the other side of the hepatocyte into a bile channel, a canaliculi in the middle. So the bile is produced here and goes into the canaliculi. So what we see is that the hepatocytes have a blood-facing side and a bile-facing side. And carrying on with this explanation, let's look at another diagram. So here we have the central vein on top here. Now, here we have a branch of the hepatic artery taking blood into the sinusoid. So this is the sinusoid here. This is the sinusoid, taking the blood through to the central vein. In this case, about 30% of the blood supply to the hepatic artery, about 30% of the blood supply to the liver is from the hepatic artery. Most of the blood to the liver, though, comes from the hepatic portal vein. And that blood is also going to drain into the sinusoid, mixing with the blood from the hepatic artery, or going towards the central vein for drainage. Here we have the individual hepatocytes. In these plates that we talked about, the hepatic plates. And we notice the hepatocytes have a blood-facing side just here, allowing material to go in and out from the blood. There we've coloured in the sinusoid, the liver capillary. And they have a bile facing side on the other side. So the bile is going to come out here, draining towards this is called a caniculus, the bile channel, this small channel between the rows of hepatocytes. And that's going to drain out into a bile collection channel. That will drain into larger bile channels, which will ultimately drain into the right and left hepatic duct. The hepatic portal vein and the hepatic artery are small branches of their requisite vessels. That's a branch of the hepatic portal vein, that's a branch of the hepatic artery. And central veins will join together to form larger veins, which will have ultimately join the hepatic veins to drain the blood back into the inferior vena cava. So what we see is that blood is flowing in one direction and bile is flowing in the other direction. The inward flow is actually called centripetal flow, so the blood is flowing in the centripetal direction. And the bile is flowing out in the centrifugal direction. The flow of the blood and the bile in opposite directions. Now going on to yet another diagram, we said that these liver lobules are actually arranged in columns, a couple of millimetres high maybe. So here we see the hepatocytes in a more three-dimensional picture. And these are the individual hepatocytes, the liver cells. The actual individual liver cells are about 15 to 20 micrometers in diameter. They're quite big for cells. And we notice that the blood is, we haven't illustrated the supply of blood vessels here, but here's the blood in the sinusoid. And we notice that the vascular endothelial cells comprising the capillaries have large gaps in between them. There's a large gap there. These are the fenestrations. So these fenestrations allow the movement of material through the gaps into the hepatocytes and the processed material from the hepatocytes back into the blood. But I think you can see this is a sinusoid here. The blood is flowing here. That will be going towards the central vein. And the bile is flowing out the way. The bile is flowing out the way like that into the bile collection channel. So we've got the two directions of flow that we see there. Now this diagram looks a little complicated on first inspection, but it's worth spending a bit of time to try and work out what it's saying, because it's an illustration of the flow of tissue fluid through the perisinusoidal space of Dis. Now the perisinusoidal space is what it says. It's the space around the sinusoid, around the liver capillary, the space of Dis. Now tissue fluid, which is high in protein, is formed because, remember, the capillaries in the liver, the sinusoids, have very large fenestrations in the endothelial vascular cells that make up the sinusoids. So there's very large gaps in the vascular endothelial cells which comprise the wall of the sinusoid, which comprise the wall of the liver capillary. So protein-rich fluid is able to get through. Now, normally in systemic capillaries, the gaps in the wall of the capillary are fairly small and we don't expect many proteins to escape. But in the liver, it's large, the fenestrations are large, so the larger protein molecules can escape from the sinusoids. So this fluid goes into this perisinusoidal space of Dis. And this fluid circulates over the hepatocytes. This allows substances from the tissue fluid to enter the hepatocytes. Substances which have been formed by the hepatocytes are also able to pass into the tissue fluid. So this tissue fluid is a good opportunity for exchange of materials from the tissue fluid into the hepatocytes, from the hepatocytes into the tissue fluid. And after circulating over the hepatocytes, the fluid is drained into lymphatic drainage vessels as lymph, as we would expect. And in this diagram, white arrows indicate the direction of the blood flow, and the small dark arrows indicate the direction of tissue fluid flow, the tissue fluid which will become lymph once it enters the lymphatic vessels. Larger dark central arrows indicate the direction of bile flow through the caniculus into a bile collecting duct. So we see that as well as the flow of blood and the flow of bile, there's also this flow of tissue fluid through this perisinusoidal space. So the pores, that is the fenestrations in the hepatic sinusoids, that is the liver capillaries, are much larger than in normal blood capillaries. This allows more water from the plasma than normal to enter the tissue fluid, which bathes the individual hepatocytes. In addition, the large size of the fenestrations allows the passage of protein from the plasma into the tissue fluids. Because remember, proteins are large molecules, but they can now escape through the large fenestrations. And this is in contrast to capillaries in other parts of the body which are essentially impervious to plasma proteins. Now, in the liver, there is a larger space between the walls of the sinusoids and the tissue cells than is normal in most other tissues. So again, the liver is somewhat unusual in this respect. This space between the capillary wall and the hepatocytes is called the perisinusoidal space, or the perisinusoidal space of Dis. Once formed from the plasma, tissue fluid circulates through the perisinusoidal space, bathing the individual hepatocytes. Now there's actually microvilli from the hepatocytes that extend into the perisinusoidal space to increase the surface area within the circulating tissue fluid. And this allows for free exchange of substances between the tissue fluid and the hepatocytes. So the hepatocytes are taking full advantage of this situation to be able to absorb from the tissue fluid, to be able to excrete things into the tissue fluid. And they take full advantage by having microvilli which increase their surface area for absorption and secretion. Now, after circulating over the hepatocytes, the tissue fluid is drained as lymphatic fluid or lymph into lymphatic vessels. From here, the lymph drains into the main systemic lymphatic vessels before it's returned to the blood. And about half of the volume of lymphatic fluid formed in the body is actually derived from the liver. So we see the liver produces a lot of lymph. Well, in this diagram we notice the individual hepatocytes, the individual liver cells just here. Relatively large cells, each with their own nuclei. The hepatocyte is in some ways the functional unit of the liver, the biochemical processing that goes on inside the liver. occurs within the individual hepatocytes. But the hepatocytes, as we know, are arranged in these plates. These hepatocellular plates. Now, one of the things that the liver does is it produces bile. The bilirubin will be taken up from the blood side of the hepatocyte, which we'll see again in a minute. And the liver only excretes the bile, or the hepatocytes only excrete bile from one side, from this side of the cell. It's pretty clever, really. They only secrete the bile from one side. And that bile goes into a canaliculi, which will drain into a bile duct. Ultimately, of course, going to the right and left hepatic ducts, joining the cystic duct to go into the gallbladder, and eventually on into the duodenum. So we see we have the individual hepatocytes now coloured in, producing bile. The bile will emulsify fats. So it's getting rid of the waste bilirubin from the blood, but it's also emulsifying fats, which is good. Now, the blood supply to the liver is via the hepatic artery and the hepatic portal vein. But here I've just drawn one supplying blood vessel. Here we have a blood vessel. It doesn't matter too much which one it is. It's supplying blood. And it's supplying blood into this vessel here, the liver capillary, which is a sinusoid. So that's the blood going in there, and the blood is going towards the centre from the periphery. So at the corners of these hepatic lobules, for a long time people have described triads. And the triad was a combination of the branch of the hepatic artery, a branch of the hepatic portal vein, but we've only drawn one of them in this diagram. And the third component of the triad was the larger bile duct. But we now know that that was slightly wrong, because there's actually 4 vessels in each corner. We'll see what the fourth one was in a minute. So there's an adjacent sinusoid there, also taking blood towards the central lobular vein, which will drain out from the lobule into progressively larger veins. So the blood supply to the liver, about 30% from the hepatic artery, about 70% from the hepatic portal vein, but both draining into these sinusoids. And we notice that the capillaries in the sinusoid, if I have a different colour for capillaries maybe, just use my pen. Here's the capillary cell walls, the vascular endothelial cell walls. What we notice is there's large gaps between these individual cells with the arrows in here. We say these capillaries are fenestrated, there's large gaps. Now, because there's large gaps between these individual endothelial cells, it means that more can escape from the blood capillaries. So normally in the systemic circulation, we would say that the capillaries have relatively small gaps between the individual cells, limiting the amount that can escape. But because there's bigger gaps here, this means that more fluid can escape into this interstitial space. So we notice there's a large interstitial space around the sinusoids. This is called the perisinusoidal space, the space around the sinusoids. So here's tissue fluid forming from the blood. More tissue fluid can form than usual, and some proteins can escape as well. So this intercellular fluid, the fluid between the cells, the intercellular fluid in the perisinusoidal space, is quite abundant. There's a lot of it because there's big gaps, there's big fenestrations. This perisinusoidal space used to be called the space of Dis, or the perisinusoidal space of Dis. And that means that material from the blood comes into contact with the hepatocytes, so material can be taken into the hepatocytes for processing. Once processed, it can leave the hepatocytes and drain. Now, most of the tissue fluid that's formed is going to be reabsorbed. So most of it is actually going to be reabsorbed and flow in this direction, not the direction I've drawn the arrows. The arrows that I originally drawn on this diagram were the flow of the lymphatic fluid. So most of the tissue fluid will be reabsorbed like this, because we know that typically tissue fluid is formed at the arterial end of a capillary and reabsorbed at the venous end of the capillary, and most will be. But there's more tissue fluid not reabsorbed in the liver than any other tissue. And of course this must be drained, and it's drained as lymphatic fluid. So it drains into the lymphatic vessel. That's why there's actually 4 vessels in each corner of the liver lobule. The first vessel is going to be the hepatic artery, the second is going to be the hepatic portal vein, the third is going to be the bile ducts, and the fourth is the lymphatic duct. And actually the liver will produce maybe up to 2 litres of lymphatic fluid per day, about half of the total volume. And to allow material to go in and out of the liver cell, these cells actually have microvilli. So I've drew one here. So if this is the hepatocyte, it's actually this kind of shape. It's got these microvilli to give a large surface area. So this would be the bile side. There'd be another one on that side, producing bile, putting that into the canaliculi in the middle, in that direction. Liver cells are two-faced. They've got a bile face, side that faces the bile, and a blood-facing side. But of course we can see that this blood-facing side is actually filled up with the lymphatic fluid, the tissue fluid. It's tissue fluid at this stage, it's interstitial fluid at this stage, in the interstitial space. It only really becomes lymphatic fluid when it enters the lymphatic vessels. So at this stage it's the lymphatic fluid. Material from the lymphatic fluid goes into the hepatocyte for processing through the large surface area and will be exported once it's processed. Any fluid which is not reabsorbed will stay in the interstitial space and will pass in this direction away. So the blood is going from the outside in. Most of the reabsorption is taking place from the outside in, but the small proportion of tissue fluid which is not reabsorbed flows from the inside out towards the lymphatic collecting vessels. So the large tissue space is the perisinusoidal space, or the space of Dis. This means that the liver cells are very well supplied with all of the material which requires biochemical processing and are able to excrete their products. So the functional units of the liver, the hepatocytes, are well supplied with this circulatory system, and the materials that flow in that direction, the bile and the lymphatic fluid, are also able to escape, readily optimizing the conditions for life essential biochemical processes going on inside each of these hepatocytes. So here we see a normal human liver with the right lobe and the left lobe. And of course this is exactly what we've been discussing in this talk, the normal structure and function of the liver. And I hope you've got some appreciation now of the fact that yes, it is the hepatocyte, the individual liver cell, that is the functional unit of the liver. That's where the biochemical processing is going on inside the hepatocyte. But isn't there just this amazing infrastructure to supply it with nutrients, to supply it with oxygen, to remove the bile, to remove the lymphatic fluid and everything that optimizes the conditions for the physiological activity of these metabolically very active individual liver hepatocytes? Now, that's the end of this first talk on the structure and function of the liver, or the way the liver is working and trying to relate the histology and the structures to the function. In the next talk, we're going to be looking specifically at individual liver functions. What is it that the liver does? And we'll see that the liver has a very wide spectrum of biochemical and physiological activity.